Okay, let's talk about this $11 billion drug, actually. 7977, GS797, formerly PSI 797, as you all know, used to be Pharmasset, which was acquired by Gilead, and this was the talk of the town in Barcelona. So among a few other things which we'll talk about today. So ELECTRON, as a little background, was the talk of AASLD with the 100% SVR in genotype 2 and 3. Genotype 1, there was 100% RVR for the ELECTRON patients. So there's a very rapid viral drop. We'll talk about that too. For the PROTON study, for genotype 1, with interferon, just 7977 interferon ribavirin, SVR 91%. So that's better than the proteases now on the market. And then the PROTON genotype 2 2-3 showed about a 94% SVR. And it's got a high barrier to resistance, which is generally a nucleotide analog attribute that's shared amongst most of the nucleotides, maybe not so much the nucleosides. So here's just to refresh your mind, actually 91% SVR for PEG and ribavirin for 12 weeks. That's 24 weeks, I'm sorry, entirely here, actually. And then SVR 24 was 91%, SVR 12, 91%. Remember, the FDA is now letting us use SVR 12. So that's going to actually also be a point of some contention. So 12 weeks of treatment. So this is the atomic, which was presented here. It had a PEG and ribavirin arm of 12 weeks. We saw these results for the first 52 patients, 7977, PEG and ribavirin. And the numbers looked really good, just like the previous study, 92%. End of treatment, 97, SVR 4 and SVR 12 all looked about the same, 92%, just the same. So PEG, ribavirin, 797, 90+%.
For 12 weeks. So
for
that
12
was the
weeks.
big point of this study, is that you could get by with 12 weeks.
12 weeks of triple therapy.
Which might be a doable regimen.
Yeah, I mean, 12 weeks of interferon is not so bad.
Yeah.
I mean, compared to 48, for sure. But now, here's the excitement stuff. The ELECTRON, we saw the exciting genotype 2-3 stuff at ASLD was 100%. It's got a bunch of different arms, though. 2-3 treatment naive, which is what we saw. The genotype 1 null responders, which came out at CROI in Seattle. We saw that there, and that was a little disappointing. I'll show you those numbers. The treatment naive data, which came out here, and the genotype 2-3 treatment experience study, which hasn't started yet. So this is why one of the rules which we've worked with all along has sort of gone away. Response-guided therapy looks like you can't use it here because everybody's negative right away. They're all negative by 2 weeks, and everybody's negative throughout the all 12 weeks here. So it's a really rapid viral suppression, and it stays suppressed as long as they're on 7977 and ribavirin. Now, the problem is for the genotype 2-3, you can see here it was 100%. For the genotype 1 null responders, it was 11%. So they stayed negative the whole 12 weeks, and then only one stayed negative after that, and 8 of 9 popped right up.
But I think that's a really strong message, right? Because it says not one therapy will fit for everyone, and that there are going to be differences. And I think what you showed before is that our usual, RVR tells the story how to treat the patients will not work because they all have RVR. But still, you have almost everyone failing the non-responder population, which I think really raises some questions. How are we going to, make our treatment decisions and how long to treat someone based on which predictors? Because we have to define new predictors, basically.
We're going to start going back to host-guided therapy, so that the host, if you're a null responder, I think we will have to decide that, and the studies will show this, whether or not duration is going to make a difference, whether or not you have to add additional other potent drugs to drive the virus down. But surely host factors are going to come into play much more now in this era of interferon-free therapies.
That's a big question that we have to go. So clearly, 12 weeks of one drug, as good as this drug is, 7977 ribavirin, not going to work for null responders. Question is, do we need to add a second drug for 12 weeks, add a second drug for 24 weeks, or just take this drug out to 24 weeks? Those are the big questions. We have a little bit of data about adding a drug for 24, which I'm going to show you.
I just want to add one thing. If you saw that Croy presentation, the one patient that did not relapse was a female that was a CC allele who probably was not really a null responder because they didn't have prior history on it.
Yeah,
So
there's
I
almost
think
no
null-
CCs that are null
Right.
responders.
So I think the nulls really don't work with 12
Doesn't
weeks.
work.
You can say that.
Now, for genotype 1 naives, now, by the way, the other caveat is these are all from Ed Gain in New Zealand, so these are all thin Caucasian New Zealanders. Okay. This
Not
is
exactly what we have.
not exactly the,
US.
what we have. Genotype 1 treatment naive, 88%.
But that's, again, is a difference to the genotype 2-3. So, already there are going to be some who obviously not. Do you have any information which kind of patients that were, which did not achieve SVR4? I mean, are these those who have unfavorable host background? I mean, are these...
Well, there was an equal mix of genotype 1A. There were plenty of genotype 1A patients in that study. So there wasn't a 1A, 1B issue.
Okay, it was not an IL-28B issue either.
It was not really an IL-28B issue
No.
either. I don't think it was consistent as to who...
No.
No, but the one thing, Doug, that I did notice about this poster was that look at week 2 between genotype 1 naive and genotype 2-3. I think that may explain some of the minimal relapse that was seen in this naive cohort, 17 out of 24 versus 100%. Again, the numbers are awfully small, and so I think we have to interpret things cautiously till we get larger sample sizes. But one wonders, and I didn't recall, Doug, in the poster if they broke out the people week 2 HCV RNA lower the limit of detection versus week 4, and I wondered if it was the week 2 more late clearance.
Yeah, well, I think that's an important point. If you look across week 2 on this chart, it's 100% for the genotype 2-3 naives,
Yes.
but 70, 70, and 80 for the genotype 1s
Right.
and the experienced.
The other
genotype
thing that's
2-3.
troublesome is that they had a press release for the quantum study where they had 15...
I put that up there, actually,
you?
just to remind us.
Right.
Because it wasn't a poster or an oral, it was a press release as a per protocol analysis. Quantum what showed a 59% SVR4. So SVR4 now.
Oh, that's a
not
different
SVR12.
patient population. In clinic.
That's an American group.
It was Geno 1, though, and it included cirrhotics.
And
Yes,
included
but I think
cirrhotics.
that's a
Included
different.
cirrhotics.
Other point is that obviously you also have to look what kind of liver disease specific characteristics the patient populations have. So if you have no liver fibrosis to begin with, everything is going to be a lot easier than if you
Good
get into
point.
that.
Well, we weren't sure about that.
Yeah,
we
but
all,
that
we all
suggests
were.
that they're
It
really
totally-
different.
Jurgen,
totally.
going back
Good
to
point.
host-guided therapy, I think the host factors are going to largely weigh into our decisions about how we approach therapy.
Well, there was a
with
lot
all
of
oral
1As
agents.
in this too, actually, as well. I think
So what's that mean per protocol, Doug? Is that because the other analyses are all ITT analyses?
So per protocol means those are the people who finish therapy.
who actually finished
Yeah,
therapy.
finished
If there
therapy.
were dropouts, if you
They
did an
didn't
ITT,
include those. Got it.
there were 2 people who dropped out or were lost to follow-up. That would
So
be
the
lower.
ITT analysis might be
would be a little lower than that.
And maybe not all patients already completed therapy. as
But
well,
that's
so-
true. There's a lot of patients that are just getting started on this.
Sure,
on
so
this
that's-
protocol.
So
Probably just the ones
we await the complete results.
Yeah, so I mean, I think the discussion we've been seeing in the newspapers about whether BMS and Gilead are partnering may be partly, they keep saying we're waiting for more results. These may be the results that they're waiting for to finish that discussion about whether to take this drug out with BMS drug or not, the cladosphere, which we're going to talk about. Now, the SVR 4, 12, 24, 36, 48 is a whole other discussion. This is this Concordance study which looked at SVR 4 and 12 presented by Eric Lawitz. Actually, and big difference here is that containing PEG and not containing PEG, they were all genotype 2-3s in the non-PEG containing arm. It was 100%. Concordance, only 16 patients though, with SVR 4 and 12 was 100%. With SVR 4 and 24, in the PEG containing regimens, it was still about 100%. So it's very close to 100%. So we can start. I don't think the FDA is going to go for SVR 4, but SVR 12 seems pretty solid. And then I think we're going to talk about an exception to that later.
But even in the study you showed, there was a week 8 relapse too. In one of the ELECTRON studies you showed of the naive patient, that was
Yes,
one.
that's
so that was
important.
after
That's an
week
important-
4
and
as
again-
well. So I think that's really important because I think we have to be careful, and that may be different if you have an interferon-free regimen, and
You got
also it may be different if you have a genotype 1, and that's not reflected in this Concordance study. So I think we have to be very cautious.
You're exactly right. The
But
Concordance seems to be excellent with PEG interferon ribavirin backbone
Yeah.
with these very potent drugs, or with genotype 2, 3, which in the grand scheme of hepatitis C is relatively low-hanging
Yeah.
fruit.
So that concordance data was only with genotype 2,
Yeah.
3. It was not with 1.
Yeah, it wasn't
so
100%.
we don't really know
Yeah.
what 1 is.
We have very little data with 1 yet. So it's going to be an interesting few months here as these things come
Yeah,
out.
but I think it leads to an over-exaggeration of the data, because if everyone gets negative at week 2 and everyone has SVR, well, then everything is going to be concordant to a certain point. But if you then suddenly have patients who do not respond at all, then I think the risk also for having different relapses may be different. If you cure everyone anyway, because it's such a potent therapy and you just don't need so long for genotype 2, 3, then that may lead to a different rule than if you have a more difficult to treat genotype 1, which differs between 1A and 1B, differs on the amount of fibrosis, and then that all can play into very differently. And I think so. I think we really have to be careful. And I think several people in the audience really got up to the microphone and said, we really have to be careful. We can't, extrapolate that all these short-term results really reflect the long-term outcome.
Good point. Good point, Jürgen.